Marston. Welcome. This is presenting today. We'll be meeting everybody who signed.
Nothing.
We got a feedback, as you can hear already. So unfortunately, you will all be muted during the session, and in fact, during the question and answer session, we will mute you as well, which sounds a bit unreasonable. What we'd like to do is control that a bit so people can hear the questions. If you have a question or have an issue, there's an icon on the right-hand panel. It's a hand icon, and if you click on that, we will see that, and we can, at the appropriate time, unmute you and have you ask your question. The other thing is that there's a text box there, and you can send it to everybody, all participants, or you can send it to the host or whoever you want to carry on a conversation that way. So there's two ways to communicate, even though you're muted, but just to let you know. Again, we will be recording this in 1 second. Before we do, I just want to take the opportunity that this is an event brought to you by a number of organizations. The BC Patient Safety Quality Council, the BC Ministry of Health has been very supportive of this. The Fact Medicine, the eHealth Strategy Office, and Evelyn works for them and with them. And with this, WEDOC is also supporting this and Evidence to Excellence. The important thing I want to point out is WEDOC is the Western Emergency Department Operations Conference, and it's coming up April 26th to 27th in Calgary, and so you have time to register. It is the West in Calgary. Sorry for the fuzzy slide, but this is the program. The Honourable Minister of Health for Alberta will be opening the session. Then we're going to talk about things like what are we going to do with grant, how are the inmates running the asylum with system accountability, customer service, how do we develop patient focus, and talk about things like provider culture, how it affects care delivery and quality. And on the 50 Shades of Triage, Dr. Tom Noseworthy will be also talking about clinical networks and variance management, ED Surge, department throughput innovations, staffing your emergency department, and Jody Crane from the United States will be talking about leading change in healthcare. So these are all important topics, relevant topics that you would and should attend if you can. Registration information is right on the slide, and I'm really saying this for those who are joining us by audio only, but the registration online is HTTPS. There's an S at the end of the HTTP. CME registration, all one word, .ucalgary.ca. And so that's my plug for the Western Emergency Department Operations Conference, which is worthwhile. So I'm going to start to record this session and then over presenter controls to Brian. Should I record onto my computer?
Ready for the session.
Sorry.
Too, if you want.
It's
okay.
Yeah, this is being recorded.
Already being. Oh, there it is. Okay, sorry. Did I push that or did you?
No, I did.
Oh, you're so smart. Okay, Evelyn.
No
and Brian, do you see your slide addressing ED overcrowding? That's your slide? You do. Perfect. I introduce Dr. Brian Rowe. He's a professor of emergency medicine at the University of Alberta. He's a Tier 1 Canada Research Chair in Evidence-Based Emergency Medicine, and he co-directs the Emergency-Based Practice Center, is co-editor of Cochrane Airways, and the editor of the textbook Emergency-Based Emergency Medicine. He is also the Associate Dean at the University of Alberta. So thank you very much for doing this, Brian, and welcome.
Thanks, Julian. So I have a bit of a cold today, so I hope I can be heard. As Julian said, I wear a lot of hats, so that usually means that I'm not able to do anything. My disclosure I have no comments relating to this topic of presentation. People here to recognize that I was not the Wild Rose Party candidate for Old Alberta. You can see it. Slide here shows that I am the representative there, but it's dubbed in by one of my emergency colleagues who hasn't published a paper in years and has too much time on his hands. So on this presentation, I'd like to go over just briefly overcrowding as it relates to the emergency department, what the consequences are and why it's so important to address this. And we've been involved in interventions to mitigate overcrowding. So I was asked to present a couple of the examples and then some of the lessons that we've learned. Apparently it's supposed to be finished in about 45 minutes, so I'm going to try to keep that the timeline if possible, and we can have some time for questions. So I'll start with my conclusions, because I think if you're really tired or you're really bored, you can leave and just keep this slide to yourself. There's no question that ED overcrowding increases morbidity and mortality in patients seen in the emergency department. I'll show evidence for that, but I'm pretty clear if you're going to be arguing for or against overcrowding, this is probably the most powerful piece of evidence that we've got now. The conceptual model for overcrowding involves input, throughput, and output factors, and factors are also the same factors that are involved in interventions to mitigate overcrowding or reduce overcrowding in the emergency environment. There's a question again from this presentation that you'll see. The implementation of solutions requires careful attention to quantitative and qualitative outcomes and to the hospital system, so that we know that each hospital is slightly different and each region is slightly different, and it has to be tailored to those factors. And then, based on experience and the evidence that's available to us, we think that system-wide strategies are worth it. It's a lot of work, but I'll show you some evidence that it actually is effective. So this is the reality in most urban EDs in Canada. You take a number and weight. It's been really bad over the last decade, and it's been increasing. So this problem is not easily solved, and it's not going to go away quickly. We've, for example, Alberta expecting an extra 100,000 people a year over the next 2 to 3 years. It's great to Alberta to work oil sands, to take advantage of no sales tax. So this is the kind of thing that is going to be a problem overall. We've had about 20% increase in our volume in a year, which is almost unprecedented. We've never had that kind of run. And so learn to deal with the increased patient needs and demands is an important thing for emergency departments. So just to start with some definitions, NIA and CAPE have developed a joint statement that is being updated this year, which defines ED overcrowding as the demand for emergency services are exceeding the ability of the emergency department to provide quality care within appropriate time frames. So I think we need to recognize that not just about time, it's about quality. We've spent a lot of time saying, see this patient within 4 hours, but we also need to say, see this patient within 4 hours using evidence-based care that's of highest quality. We have evidence that overcrowding was described in the early 80s, and really in Canada it appears to be mainly an inpatient issue. So patients admitted to the emergency department who couldn't get a bed upstairs. There's been little attention paid to it in Canada until probably the last decade, and I think people who've been involved in this issue for many years are impressed with the movement that's occurred probably within the last 5 years. And certainly in our own province, the activity associated with ED overcrowding has been different in the last 5 years than it was in the previous 25. So this is a redefining issue for the healthcare system. This is the conceptual model adapted from Asplin. Brent Asplin is an emergency physician Minneapolis, Minnesota, and colleagues across the North American continent. Looks at input, throughput, and output factors, and then overall system-wide influences. And of input as being referred from family doctors and outpatient clinics, in patients who have patients that are unique, that require emergency care, and ambulance referrals. Throughput includes, many of the things that we do, including triage, diagnosis, treatment, and decision on admission or discharge. And the output includes mostly admission and discharge, but also patients who fail to complete their care, either by leaving without being seen or against medical advice because delays are long or because they don't agree with the management approach. It's a conceptual model. We'll return to it a couple of times in this talk to understand how we are best suited to improve overcrowding. So what we care, Canadians are still waiting, waited for the post office. We've waited for the economy in the U.S. to recover, and we're still waiting for the Stanley Cup to return to Edmonton. It probably will occur this year because I don't know if you know, but we've won 5 in a row, and that usually means that you can win the Stanley Cup. At least that's what the radio suggests. Anyway, the consequences of overcrowding in the emergency department are substandard medical care. So delays in time-sensitive treatments like antibiotics for infection, particularly severe infections and sepsis, thrombolysis for AMI, thrombolysis for stroke. Time interventions like these require an emergency department that's functioning well. And when the rubber band is stretched particularly tightly, it's difficult to accommodate those patients. From an outcome perspective, prolonged length of stay in the emergency department has been shown to be detrimental to patients. Are really best suited to deal with patients in the acute phase. Once they're 2 or 3 in the emergency department, they're not going to be evidence-based. We know that there's increased death from certain conditions that occur in the emergency department when there's overcrowding. There's also an increased risk of medical error and patient safety concerns, and that's been well documented. There's increased risk of contagious disease spread and illness in the emergency department in overcrowded situation. I was in Taiwan teaching last week at the Chunga Medical School. We went to see their emergency department. There were 20 patients into the hospital waiting for transfer to the floor. It's a 3,500 bed hospital. And there was about a foot between every bed. There's no way that somebody had an infectious disease that the entire department wouldn't have caught it. So infection control is a huge problem in overcrowded EDs. From a resource perspective, patients suffering are bad news for nurses and physicians who are working there, other health professionals like RTs, orthotechs, all the staff that work are satisfied with their job when there's a lot of overcrowding. Increased sick time and absenteeism. Their phone, they're I think a bit of feedback. A really interesting paper in CGEM about loss of privacy and dignity associated with overcrowding, and I would encourage you to look at that one. It's really a beautiful piece and really talks about how patients experience overcrowding. And costs associated with overcrowding have been reasonably well documented. But how bad could it get? This is Michael's group, Gutman, published in BMJ in 2011, and it shows that waiting an additional hour, their adjusted odds ratio for death and admission to hospital increases. So by the time you've waited 6 hours, you have about a 70% increased chance of death compared to other people with similar CTAS scores and age and sex, and the same for admission to hospital. Now, you see at the top, patients who leave without being seen have a low risk. This to be confirmed, but the gradient of the causal effect appears to be valid, and other people have documented this as well. So it's pretty clear that the longer people wait with CTAS scores, the more frequently they're going to have admission to hospital or they're going to die. So they get sicker in the emergency department or they get so sick that they die. And I think that's the kind of message that we should be sending to administrators and the public and the healthcare systems that we work in. Overall, it's bad for patients, staff, administrators. Everybody has headaches associated with overcrowding. It most often affects, at least in Alberta, we've documented this fairly clearly, urban large volume EDs, trauma referral centers, teaching centers have the largest overcrowding. There's some really busy community emergency departments as well. They're really underrepresented in this field, but certainly that we've heard that they are also overcrowded. The issue is that patients in the ED system usually the cause of the backlog, so they can't see patients in the emergency department because no beds to see them in. And then we have evidence that efforts to mitigate ED overcrowding are worthwhile. So what are potential solutions? Well, we were involved in the development of a knowledge synthesis project with the Holy Council doing this kind of work, and we returned to that conceptual mod of input, throughput, and output. And here is the report. It's freely available. We made no money on it. In fact, I can guarantee we lost money. We did a review and it was released in January 2012 as a result of several initiatives in the province to look at physical intimidation, overcrowding issues, and efforts to mitigate it. This was called a rapid review. So some of the evidence contained within this document would be a full systematic review and health technology assessment. Others are rapid reviews of primary studies of selected interventions. So again, it's freely available. I'm just going to summarize the main findings and then focus on 3 or 4 initiatives that have done and have looked at in our own department. These are some of the or input issues that people have identified: decreasing the demand for emergency department and diversion of care in the emergency department. And from the report, you can hear that for example, the media campaign has been particularly ineffective in reducing ED overcrowding. Improved access to primary care. There's some evidence that works, but it's not particularly strong. Things like prevention and helmet laws and seatbelt laws have been effective. Disease management has been effective in selected cases, but in general, there's not a lot of evidence that we can reduce the input. And there's actually some pretty good evidence out of Michael Scholl's group. Those ambulance diversion is detrimental to patients. So many centers have stopped permitting ambulance diversion, and probably rightly so. So the message here would be input factors are not easily changed, and there are not many effective measures for them. So one example that we're currently doing, and you can see here, this is April the 3rd, 4:21 p.m. Edmonton. There's also one for Calgary. This is the real-time reporting ED wait times. It's on a convenient AHS website. I went to this yesterday just before my shift. And you can see here, the University of Alberta had a 1 hour 47-minute wait time. I started at 5, and by about 7, the wait time was about 3 hours. Now, my staff said that was largely because of me, but I think that everyone knows that there's a volume increase in the early evening hours with the end of the work. So I pointed that to them and hoped that they weren't going to blame me for it. You can see here that the would be reasonably at that point. If you assume that patients can judge themselves and decide which hospital they need, that's a fairly large assumption. The validity of the data is often questioned, And in reality, there's no good evidence to suggest that real-time reporting affects patients' decision to choose their emergency department. The places in the country, it wouldn't be appropriate because there'd be one hospital or the most appropriate hospital for that patient. So, an example of an effort to reduce input, which has largely not been well and we aren't entirely clear if this is beneficial. So, from an ED throughput perspective, here are some of the initiatives. The patient gets treated, the nurse sees them, they wait for a doctor, the doctor does diagnosis and management, and then a decision is made. So here are some of the potential interventions. So, for example, triage nurse ordering, triage liaison physician, rapid ED care maps, staffing levels, lean approach, and primary care. So here, some of the starting to get a few more positive impacts in the throughput area. For example, we've published an article on triage nurse ordering that shows that it might be as effective as we think in medical conditions like abdominal pain or heart disease or chest pain, but it's very effective and reduces length of stay for minor musculoskeletal problems. So, for example, an injured wrist, an injured ankle, an injured shoulder have been trained to order radiographs, and this strategy has been shown to reduce emergency department wait and length of stay overall. So I'm going to go talk about the third one, which is triage liaison physician. This triage liaison physician concept came out of the UK. It's a novel intervention to deal with overflowing waiting rooms. Now, you could argue that there are ways of dealing with this, like unlimited your emergency department, but at the time, we did this in 2006, we didn't have that option, and so we needed some solution for the emergency department. The evidence was relatively low quality, and we weren't entirely sure of the benefit, but health authority willing to help us perform a randomized controlled trial to determine whether this was effective. It was published in Academic Emergency Medicine 2007, if anybody wants to see it. So the question was, adult patients in a urban high-volume trauma center doing a triage liaison physician shift, one per day for 8 hours, improve length of stay, reduce left without being seen against medical advice, and nurse and physician satisfaction compared to the traditional physician shifts. So this physician would be at the front of the emergency department dealing with patients, expediting their care, and assisting the physicians in the back. So this unblinded parallel group randomized controlled trial. The reason I put methods in there is because quite often very good ideas come out of good, hardworking clinician groups, and there's no evaluation of the implementation. So in this case, we actually a scientific study to try to with the health authority for the benefit or associated with this intervention. So we block randomize, and it's important to kind of understand what that means. So we'd have a 2-week block, and then each week there'd be one day that was an intervention and one Monday that was a control. So in the 2-week block, you would pair your each day of the week so that there was one intervention, one control over a 2-week period. Did that for 4 blocks. And so it's a type of method that enhances the validity of the results. So the control days were just the usual emergency shifts. There were 7 for 8 hours. And the intervention days, the triage liaison physician would come in for 8 hours between 10 in the morning and 6 in the evening. And we collected what we would consider to be unbiased data in the form of administrative data from the electronic medical record. And what you see here is there's about a 36% or a minute reduction, which is statistically significant between the TP days and the control days. And then there's a reduction in length of stay for CTAS 3 patients, which we consider to be the most difficult patients. They're often the most complex. The dispositions are much more difficult. So they were reduced by 39 minutes. And left without being seen was reduced, again, statistically significantly from 7.9 to 6.3%. So you could argue that while your length of stay is still beyond what it would be considered the target for Canada and for other parts of the world. So this is still clearly a very congested department. But at the time, we had almost 3,000 patients in the control days and the treatment days. And data demonstrates a really impressive reduction in the length of stay. And this was for all 24 hours, despite the fact that the emergency extra physician was only available for 8 hours. So our quantitative research showed an important outcome. The qualitative research did surveys to ask physicians and triage and charge nurses whether they favored the shift. And physicians overwhelmingly favored the shift because it allowed one physician to take the telephone, take all the incoming calls, and to help with procedures and other activities. The triage felt that they were supported and they liked having a physician at the front, and charge nurses felt the flow was improved. So overall, the decision was to continue and expand the intervention as a triage liaison physician. So that intervention was supported by the region. It had previously been 2 a day at the University and the Royal Alex, and at the 3 community non-teaching sites, or not as aggressive with the numbers of learners at the other sites. It was given 1 8-hour shift per day. Now, technically, despite all this evidence, we've since published a systematic review that shows that this evidence is now pretty overwhelming. Health Authority, due to budget crisis, just recently canceled this initiative and removed 2 shifts a day from the emergency department. So, even with evidence, sometimes it's hard to continue these kinds of activities. So the third example is RAS unit, and I suspect many of you have your own experience with RAS unit. Ours was a RAS unit where patients were in a waiting room beside the 2 beds, and they were cycled through the beds as a way of executing their initial assessment and management. The evidence for RAS units is relatively low quality, and the benefit is unclear. It probably depends to a certain degree on the type of hospital you have, and you'll see in a minute that our hospitals may be different from the that you are all working at, and so you have to decide for your own system whether this is going to be effective. We completed a very similar randomized controlled trial of the RAS unit compared to the traditional patient locations. We wanted to look at this in the same emergency department. Outcomes were the same: length of stay, without being seen, satisfaction, and it was a similar unblinded parallel group randomized controlled trial. And in particular intervention, there was a 27-minute reduction in length of stay overall, and CTAS 3 patients less of a benefit. We suspect that those patients, you look at the length of stay there, it's 9 hours, 9.5 hours, not really a lot of difference and probably not clinically important. And left without being seen didn't change at all. So depending on how you would perceive a 27-minute reduction in length of stay, either from a patient perspective or your own department, this was a successful intervention. So there was some improvement in the quantitative results, but we did the qualitative research. The physicians overwhelmingly disliked the change in the flow. The triage nurses felt that TLP was distracted and was not participating in the work at the front of the department. The charge nurses felt the flow was unchanged, and so the decision of this intervention, despite this evidence here that shows some benefit on length of stay, the decision was to not continue that intervention. So again, the evidence needs to be both quantitative and qualitative. the staff in the emergency department need to be surveyed after an intervention is implemented to determine whether it's working their work cycle and their flow. And in case, no matter what about the effectiveness here, the physician and nursing group voted it down. The third example is something we called volume-based staffing, an intervention to add additional shifts during periods of high volume. We tend to have a sort of static physician staffing model, and we again there was a need to at least experiment with it. And this is a physician group that had really resisted change for many years, and the way they would do it, in fact, it was posed by one of the clinicians in the group, not the research group, that would do a randomized control trial and do both quantitative and qualitative research methods to determine the effectiveness of this intervention. So it was a bit, for a research group, it was gratifying to have them propose as one of the solutions. Again, back to the University of Alberta Hospital, it's a 55,000 patient emergency department with a pediatric hub of an additional 35,000 patients. It's all full-time dedicated emergency department physicians with some level of training, either EM, ABEM, or FRCP. It's a high referral and ambulance traffic with 23% admission. So 1 in 4 of the patients that we see are admitted. Now, there are different sections of the emergency department, one being the acute care radiation side, and that admission rate might be 50%, whereas the what we call the CD and E pod, which is more respiratory, abdominal pains, and injuries, their admission rate would be lower. But overall, 23% of the patients presented to this department are admitted to hospital. So the staffing model was 8-hour shifts, every day, exactly the same, weekends and weekdays. We had no on-call system. The TLP was funded, and the TTL was funded. So if there was trauma, a trauma leader would come in and take care of that, and then there was a triage liaison physician from 8 in the morning to 2400. We did have a pod system at the time and no res, and the hourly start times for physicians are shown there with a total of 56 hours per day. The pre-treatment or pre-intervention, you see that the all volume has gone up dramatically, particularly in the last couple of years. So this is a place that's got a lot of overcrowding. And again, the rationale was to evaluate the impact of adding an additional shift during the daytime hours. Get PICO questions, high volume emergency department, 4th physician versus 3, length stay, admitted and discharged patients, left being seen, and improved MD and nursing satisfaction in the same fashion as we had been doing in the other 2 trials. So this one was a bit longer. The control days, we brought in a physician from 9 to 5, 2 to 10, and 7 to 3 in the morning on that side. In the intervention group, we did 9 to 5, 1 to 9, 5 to 1, and we extended the double coverage overnight. And we did exactly the same thing. We had block randomized in 2-week blocks covering 12 weeks. So it was longer than the previous one. And we asked physicians what the most important outcome for this, what's the minimally clinically important difference. The first time we'd done this, but they say uniformly that minimally important difference for time D was 30 minutes. The length of stay for admitted patients was an hour, so it would have to reduce from 4 to 3 or 5 to 4. For length of stay for discharged patients, docs uniformly said 30 minutes, so you needed to reduce the length of stay for discharged patients by 30 minutes for them to take on this extra physician, and length being seen would have to be reduced by 25%. So we went knowing what docs wanted this time from a quantitative perspective. And in these, we see before and after very similar kinds of patients, identical triage, median age, male sex, patient proportion. So you can see that basically the two periods were very similar. So it wasn't a difference that we identified. It had nothing to do with the time of year when this intervention was applied. And here are the results. And what you see in this slide is that there was about a section in time for a physician to initially assess the patient. So it went from 76 minutes to 69 minutes. Now, statistically significant, but not very clinically important. We looked at admitted patients. There were differences in the patients. And length of stay for discharge patients, there was about 20-minute reduction here. So that's not either. So you could argue that even though this difference in the physician and initial assessment is significant, it's not clinically important. Because go back to this slide, you can see that the difference had to be 30 minutes to make a difference, and this difference is only 9 minutes. So overall, you would argue that this was an ineffective intervention. Some more advanced regression modeling on this to determine if there are differences, and what we concluded was that the length of stay was clearly age and sex to CTAS level, so that CTAS 3 had an increased length of stay compared to CTAS 1 and 2, and C4 and 5 had decreased length of stay compared to CTAS 1 and 2. Obviously, there are complications, increased length of stay, but overall, the intervention period did produce a statistically significant decrease in length of stay. So it's important intervention in the shifts, but it didn't meet the criteria that the physician group used at the start of the study. Here's the left against medical advice. There was a slight decrease in left without being seen rates, and not statistically significant difference in left against medical advice. What's interesting is that this is a fee-for-service environment, and so if you don't see as many patients, then you're losing money. So what you can see here is on the intervention side, the seen per physician went from 16 to 15, and on the CD pod went from 7 to 22. So in summary, they were making less money, they were seeing fewer patients. There's really not a whole lot of benefit associated with this intervention. So, and this, there are limitations of all of these studies. This one was just at the center. There was no satisfaction data. There were long-term follow-up and outcomes, and some administrative data points that were missing. But the research showed that no clinically important difference reached in any of the outcomes. But again, the qualitative research shows that physicians overwhelmingly liked the shift change. The clinical nurses experienced less idle time. They were more active, less waiting for docs, and the charge nurse felt the flow was improved. So here's an example of a project that the quantitative evidence doesn't show a clear effectiveness. Qualitative work did that it was a better work environment for the clinicians use a new model, and there was a unanimous support for the continuation of the intervention. So again, the first one was TLP, where both effectiveness and qualitative work showed a benefit. The second one was RAS, which shows a benefit quantitatively, but qualitatively people didn't like it, so they voted down. And the third one is one that doesn't show a great effect, but no particular cost except to perhaps the physician group, but overall qualitative support for the intervention which moved forward. So again, both qualitative and quantitative aspects of the evaluation of these interventions is critically important. On the ED in the output component of the ED overcrowding model. Well, this again goes back to the Health Quality Council review. What you can see here is that there's a lot more positive things. So what actually works? Care on the floor, planning, ancillary staff, discharge priority setting. Those kinds of things. Now we're getting almost every intervention that improves output is reducing length of stay. What about solutions? So we've talked about the compartmental input, throughput, and output component of the model, but there are system-wide solutions such as pay-for-performance, benchmarking, accountability frameworks, and system-wide initiatives like multi-level interventions. And in general, pay-for-performance, benchmarking, and accountability interventions have been shown to be effective. There's some debate system-wide initiatives. We've had some experience here where system-wide initiatives both worked and didn't work, but there are other examples where it's very effective. So here's the final example for the day: wait time strategies, or targets for ease, and you can see that in every province it's slightly different. So, for example, in Quebec, they've got high acuity and low acuity discharges are not differentiated in that model, whereas in Alberta, they are. So they're looking for rapid turnaround on patients. The 4-hour rule comes from the UK model, which has been shown to be highly effective at reducing length of stay for patients in the emergency department. We feel that there's been a lot of focus on time and less of a focus on quality, and we want to balance that equation and not patients rapidly and have them discharged or admitted quickly. We want to make sure that the evidence-based care that's being admitted to these patients is appropriate. So there are a variety of options available to address overcrowding, almost like a smorgasbord or a buffet for hospitals and regions. Each hospital clearly is unique, and I wouldn't say that there are many cases like the University Hospital, and even within the city of Edmonton, all 5 of these major hospitals, maybe 6 of these major hospitals, are very different. And so it requires each unit to make a decision about what is going to be the most effective strategy. So a place sees 5% admission rate, has a lot of ambulatory care, might do very well with a RAS unit. A low admission rate, a mental assessment unit would be less effective as a strategy for them. I think it requires pretty dedicated and courageous senior leadership. And the senior leaders in most hospitals and regions were interested in emergency department overcrowding and largely ignored it. Many of you with the same gray hair as me will remember those days. And now it seems to be an increased interest and awareness of ED overcrowding. Certainly, if we keep them and telling them what the consequences of this healthcare crisis are, it's hard for them to ignore it. And there's certainly evidence across the country that things are moving in a positive direction. I think to be careful that expectations aren't overly large. We're seeing modest gains, and it's an iterative evaluation that's really critical in this environment. What I want to try to avoid is this situation where everyone's in the same bed. This is equivalent to the Cao Chungung Hospital in Taipei. I was visiting a couple of weeks ago, where really the patients are almost in the same bed. We want to avoid that in probably Taipei as well as in Canada, move towards an environment where patients receive timely care that's high quality and evidence-based without any of the risks associated with the overcrowding model we're all experiencing now. That's the end of my talk. I'd like to thank Julian and E2E for the opportunity to share some of this with you. My mission has always been that all the evidence is what we need to make decisions. We've given an example of 3 randomized controlled trials that were done really at very little cost to the healthcare system that made a big difference in how we serve our emergency department. I think there's lots of really good ideas out there, and I'd like to encourage people to continue to work on them, to evaluate them, and eventually have them in press somewhere. And I put a plug in for the Canadian Journal of Emergency Medicine. I'm a senior associate editor at that, and we're always looking for operations and ED overcrowding literature and submissions. So I'm going to left my email there. If there are any questions that I don't get to today, please email me, and I'll respond quickly to you. And Julie, I'll hand to you guys to the questioning.
Great, Brian. That was an excellent presentation. As always, as I've always experienced when you present, the amount of work that you've got done, you and your group have done to come up with this information is amazing. And I can sense some of the frustration probably with the fact that you show good results and yet it doesn't get sustained because of funding issues. But we have 15 minutes, and we have to get off of this line, I'm afraid. So I will remind people that you can either raise your hand and we will unmute you to ask your question, or you can type a text question into the chat box on the right-hand side. And the hand icon is on the right-hand side as well, below all the names from the participants. So please raise your hands. Brian, while people are sort of warming up here, I'd like to ask what do you think are the actual measurements, the outcomes that are worth reporting and looking at? What I mean by that is, what's those providing the funding, what are they interested in dollars? How much are they swayed by length of stay, nursing satisfaction, and so on? I realize I think what you're doing is fantastic. I'm just wondering, in your sense of the whole big picture, if you were to have the ideal system and be able to capture any data you wanted, what would you capture, and what would you do going forward? Does that make sense?
Well, I think the most satisfaction work is really important for the group. This is the University Hospital is really important for us to survey them and figure out what they. So internally, that's very important. I don't think the authority or the CEO of Alberta Services really would care if we increased nurse satisfaction by 1 point on a 7-point Likert scale. I agree. There would be a different role for patient satisfaction or for staff satisfaction in this research. But I think that length of stay is probably the most universally acceptable outcome for most of this research, and I think we need to be very granular with it. For example, if we just say length of stay, and we've got a lot of admitted patients, it's going to be skewed to the patients that stay for 24, 36 hours in the emergency department, and so your medians, your mean values are not as valuable to me as the median. In addition, I think you should separate them out into CTAS 1 and 2, CTAS 3, and then CTAS 4 and 5. In order to do CTAS 1 and 2, or high acuity patients versus low acuity patients, I think you get the could be more granular in detail. You need to separate them out into admitted and discharged patients. And then I think left without being seen is a really important marker of overcrowding. So obviously some people leave because they really have anything major, but I like the reporting left without being seen, because to me, whenever we're overcrowded, we have virtually no left without being seen. When our overcrowding becomes a major issue, our left without being seen rates are very high. I'm still not convinced, and if Michael's on the line, we've debated this many times, I'm still not convinced that left without being seen is a benign outcome for patients. And again, we've seen some evidence to suggest that they come back more frequently and they have adverse outcomes. But I think this needs to be reiterate that left without being seen means that these patients have not completed their care, so we don't really know what they've got. And so the bottom line is if we report to stay and being seen and do granular exploration of the left without being seen, I think that's reasonable. It's very difficult to see data. Mike's group did a much larger database analysis. It would be very difficult for individuals to report mortality outcomes. But other kinds of surrogates for adverse events like hour or 7-day return rates, which again are fairly low level, but they could be used as an outcome measure for safety. What you're trying to do is use the data that's collected administratively so that you can report outcomes that aren't going to take you hundreds of thousands of dollars and many hours to do a chart review.
Perfect. Thank you very much. I'm going to let others ask questions. I can't, I'm sorry, Lynn, maybe you could help me. I only see actually one hand up now. I know Eric had one up before. So I'm going to go first of all to Brooke, and we've just unmuted you, Brooke. If you could ask your question. For some reason we can't hear you, and I hope you're okay.
What about the ones on the chat?
Yeah. And
how about now?
Oh, sorry, Brooke?
Yeah, I had myself on mute.
Oh, double muted yourself. Perfect. Okay.
I work for Fraser Health Authority, and the question I have is either directly or indirectly the experience you've had with the concept of your hallway or mine in regards to where it's best placed to put admitted patients that are congesting the ER, is sending them up to the units and have them as hallway patients.
So that's really the overcapacity or full capacity protocol some sites are doing. It was popularized by Cello in New York, who was able to, in hospital at least, they would up to the floor, and 50% of them had a bed as they came through the elevator. Another sort of 30% within an hour of arrival, and then the rest stayed for an average of 8 hours. That was a private hospital, bring a large area with actually some inefficiencies in their admitting policies. So in Canada, most patients who are admitted are not admitted for any kind of social reasons, apart from, in rare cases. The patients that get admitted now to Canadian hospitals tend to be sick and they need the inpatient environment. Those environments are already at capacity in many places. So the overcrowding, the overcrowding, full protocol is different here than it is in the States. So the evidence for its benefit is rather limited. Even in Vitello's case, he hasn't published much of that data, and very good speaker. Loved listening to him talk. He's got great stories, but there's not a lot of evidence that it's transferable elsewhere. So in our own province, we have some evidence that if you're really congested, that is a very effective strategy. And, the patient floors don't really like it, but it is kind of sharing the pain, and it does force people to think about, whether they should dish Miss Jones in bed 5, who's been there for a week with pneumonia, and the average admission for pneumonia, for simple pneumonia, at high is less than that. So they would be forced to discharge those patients. And hasn't had a particularly good experience with the overcapacity protocol. However, Calgary has had a more, sort of a better experience than we've had. It may be because of Grant. Grant Innes is in Calgary, as you know, and is a big supporter of this initiative, and he's a very persuasive guy. And so he went around and did a lot of in services with the staff in Calgary, and it's been a more accepted intervention. So, that seems like a kind of wishy-washy response, but I don't think the evidence is clear as we think. And, you know, if there were, for example, in our own hospital, we do as much as the county hospitals, but we have had some improved flow through an inpatient initiative with general internal medicine. So, again, I think you have to choose if that's the right initiative for your institution. There is some evidence for it, and there is some evidence against it.
Thank you, Brian. The next question comes from Eric G., who I hope is not related to Ali G., but knowing who Eric G. is. Great, Brian. I noticed that you measured staff satisfaction. Did you do any work to see if your interventions impacted patient satisfaction?
Great question. We didn't specifically. In Alberta, there's something called the Health Quality Council of Alberta, which was the group that funded the overcrowding reviews. They do patient satisfaction surveys, and the patient surveys are about 55 questions. And again, all of these studies that we did were unfunded. So to get patient satisfaction surveys would require a lot of effort, a lot of money that we didn't have. So I think it would be great if we, you know, in an ideal world, I think it would be fantastic to get patient satisfaction, because I think that patients who get seen rapidly and by emerge physicians and clinicians who are dedicated to their craft, they're satisfied. In fact, it's clear from patient satisfaction data that satisfaction is driven by length of wait. So if you don't wait, your satisfaction is going to be high. It's not like they see the difference in quality after they've waited for 3 hours. They're just about waiting for 3 hours, and so their satisfaction with care drops. So I would love to see that. You know, it's a pragmatic issue. We just don't have that kind of funding for a lot of these projects. And again, while I think patient satisfaction is an important metric, I think it's as important as the administrative data that's more easily collected and which gives us data on every single patient. And most of the patient satisfaction surveys get more than about 30% response. So, you know, for all those missing patients, we don't know if they were super satisfied or super dissatisfied, and that's why they didn't respond. So you can get data on patient for left without being seen and length of stay, and so that's why we focused on that. It's also cheap as hell to get.
Thanks. Another question. We got two questions left, Brian. This one I believe is from Garth. Sorry, I don't see the name. Anyway,
Garth.
Do the factors and potential solutions to overcrowding differ between adult and pediatric centers? Speaking of urban, academic, and large centers.
Yeah, that's a great question. The pediatric literature is a little bit different. So, for example, in Left Without Being Seen, the pediatric literature, those children leave because they get better. Whereas in adult literature, those patients leave because they're mad. They got other things to do. They got child issues. They got whatever. Parents who leave the emergency department with long waits, they're generally leaving because, oh, Johnny's elbow back into place when he was over, you know, play of the emergency department, or Jeannie's fever has gotten down and he's now drinking, or, you know, maybe it looked like she was, you know, dehydrated, but now she's drinking her fluids. So the reasons for the wait may be the same, but Left Without Being Seen, for example, there are different reasons for people leaving. So I think that it needs to be examined slightly differently. We've done most, because our hospital is an adult hospital that we focus on, but we do have a pediatric emerge behind us, and I think the issues are very different.
Another question, I believe this one's from Blair. The question is, what is a reasonable admission rate? We are seeing approximately 125 patients per day. Admit rate is 8 to 9.
Well, you know, to be honest with you, I think, I'll just give you the example in Edmonton. We have the Royal Alex Hospital, which is a trauma center. It's a big teaching hospital, not affiliated with the the academic center at the University of Alberta, but they have about closing in on 20%. We're at 23%. Then the two busy community hospitals, the Grey Nuns is just over 10%, and the Misericordia is just under 10% for admission. And the community hospital slightly outside of town has an admission rate of about 6%. So each hospital is slightly different. And so places that get lots of trauma, lots of referrals, they're going to have a pretty high admission rate. So I don't actually think there's a rate acceptable. It depends on the institution. And I fight saying that we have to get to 8%. I think we need to do a bit more work on who needs to be admitted. So, for example, when I graduated from medical school in 1900, that period, everybody intravenous heparin who had a swollen leg, they all came in Friday at 3 o'clock, so we couldn't get any tests done on them. And by Monday, they have a whole weekend full of subtherapeutic or super therapeutic INRs or PTTs, and then get their image on Monday. Some of them did the intervention for the whole weekend, and others of them did. And now we don't do that. We do DDOs, we do ultrasounds, we do VQs and CT scans. We make decisions. Many of those patients don't get admitted to hospital. So back 20 years ago was probably appropriate because that's what the diagnostic algorithm was. But now everybody should be using the Wells criteria for DVT, using D-dimers and imaging on a convenient basis. And very few of those patients need to be admitted. So, and we need to do more of that kind of work to say that's appropriate admission. I think 125 patient emergency department, depending on what kind of department it is, at 8 and 10% is probably appropriate. If you're in a major trauma center, you're not a referral center, there's not the same demand on the services as there would be for an academic health science center. And I suspect there's places that have much higher admissions than ours as well.
Julian disappeared for whatever reason, but we are still on, but we should probably start wrapping up. Okay,
I don't see any more questions online.
So there's just one more question from Doug. Brian asks, do you have any information on the impact of hospital in the home as a means to mitigate input?
I don't have any, we didn't include that in the systematic review, and I haven't done a ton, but that's a great point.
I guess I'll wrap up on behalf of Jan. Thank you, everybody, for joining us today's webinar. Thanks, Brian, so much for taking your time to join us. And yeah, the recording will be posted on the Evidence to Excellence website tomorrow.
Great.
Okay, thank you.